What if I tell you that erectile dysfunction is not just a sexual problem, but maybe the first warning sign of heart disease? In fact, many patients develop erectile dysfunction years before they develop symptoms of coronary artery disease because the penile arteries are smaller and get affected earlier. Erectile dysfunction, or ED, previously referred to as impotence, is defined as the inability to achieve or maintain a rigid penile erection sufficient for satisfactory sexual intercourse. Although no strict duration is required, in clinical practice, it is often considered significant when it persists for several months. ED is a very common condition, especially in men over the age of 40, and its prevalence increases with age and associated comorbidities. ED is not just a local issue. It often reflects an underlying systemic problem. Any condition affecting blood vessels, nerves, hormones, or smooth muscle can lead to ED, which is why it is closely linked to diseases like diabetes, hypertension, and cardiovascular disease, with endothelial dysfunction as a common pathway. While older patients usually have organic causes, younger patients often have a psychogenic component, though psychological effects can be present in all cases. However, the key reassuring point is that erectile dysfunction is almost always treatable, and with a proper understanding of its underlying mechanisms, effective management can be achieved. The penis is composed of 3 cylindrical erectile bodies, 2 corpora cavernosa and 1 corpus spongiosum. The corpora cavernosa are the main structures responsible for erection. They are made up of sinusoidal spaces lined by endothelium. These sinusoidal spaces are vascular spaces, that is, these are filled with blood. These spaces are separated by trabeculae, which are composed of smooth muscle and connective tissue. These spaces can rapidly fill with blood during erection. Surrounding the corpora cavernosa is a tough fibrous layer called the tunica albuginea. The tunica albuginea is tough and relatively non-distensible layer, whereas the corpora spongiosum also contain erectile tissue but is less rigid. Its main role is to keep the urethra open during ejaculation. Blood supply comes from the branches of the internal pudendal artery, especially the cavernosal arteries, which give rise to small helicine branches that fill the sinusoidal spaces. Venous drainage occurs via subtunical venules. These venules lie inside the corpora cavernosa, just beneath the tunica albuginea. That's why called subtunical venules. Blood from the sinusoids drain into these venules, which then connect to emissary veins that pierce the tunica albuginea and ultimately drain into larger veins like the deep dorsal vein, which lies above the tunica albuginea. So during sexual stimulation, there is relaxation of the smooth muscle in the trabeculae and cavernosal arteries. As this smooth muscle relaxes, the sinusoidal spaces rapidly filled with blood, leading to vascular dilation and expansion of corpora cavernosa. This expansion increases the both length and girth of the penis, producing erection. Now, because the tunica albuginea is thick, tough, and relatively non-distensible, the expanding cavernosal tissue presses outward against it. In doing so, it compresses the subtunical venules, which lies just beneath the tunica. As a result, venous outflow is markedly reduced because these venules are partially or completely occluded. This mechanism is called veno-occlusive mechanism, and it is absolutely essential for maintaining erection. The reason this occlusion is so important is that erection is not just about increased arterial inflow. It also requires retention of blood within the penis. If venous outflow were not restricted, blood would continuously drain away, and the penis would remain soft despite increased inflow. Therefore, effective compression of subtunical venules ensure that blood is trapped within the sinusoids, allowing the intracavernosal pressure to rise and a firm, sustained erection to be achieved. An erection is like inflating a balloon. As long as the air is trapped inside, the balloon stays firm. But if air leaks out rapidly, it becomes flaccid. Similarly, in erection, trapping of blood is essential. If blood keeps leaking out, a firm erection cannot be maintained. Now the question arises, how the cavernosum sinusoids dilation? It all starts with sexual stimulation, which can be of two types, reflexogenic or psychogenic. Reflexogenic erection is triggered by direct physical stimulation like touch, and it works through spinal reflexes without needing conscious brain involvement. On the other hand, psychogenic erection begin in the brain, where thoughts, visual stimuli, or emotions that activate brain pathways that send signals down the spinal cord. In both cases, these signals ultimately activate the same mechanism. When we talk about a reflexogenic erection, we are essentially describing a pure spinal reflex. Direct physical stimulation of the genitalia activates sensory receptors present in the skin, and these receptors send signals through the pudendal nerve, which carries the sensory afferent input. This signal then travels to the sacral spinal cord segment S2 to S4, which function as erection reflex center. Once the signals reaches this sacral center, it gets processed locally within the spinal cord, without needing input from higher brain centers. The spinal cord then immediately sends back an efferent parasympathetic fibers through the pelvic splanchnic nerves. These parasympathetic stimulation leads to the production of nitric oxide from the endothelial cells lining the cavernosal arteries and sinusoidal spaces. Once produced, it rapidly diffuses into the adjacent smooth muscle cells of the cavernosal arteries and trabecular tissue. Inside these smooth muscle cells, nitric oxide activates the enzyme guanylate cyclase, which increases the level of cyclic GMP. This rise in cGMP leads to smooth muscle relaxation, allowing the sinusoids to expand and fill with blood, ultimately producing an erection. In contrast, during psychogenic erection, we are referring to erection that starts in the brain, when sexual stimulus like thoughts, visual input, or emotions are processed in the brain. They activate key areas such as the limbic system and the medial preoptic area of the hypothalamus. From here, descending autonomic signals travel down the spinal cord, and in the spinal cord, they influence thoracolumbar, that is T11 to L2, and sacral, that is S2 to S4 erection centers. As we know, the thoracolumbar center is under sympathetic control, and sacral center is under parasympathetic control. As erection requires parasympathetic dominance, so these descending signals enhance parasympathetic activity and suppress sympathetic tone. Once the signals enhance the parasympathetic activity, the rest of the mechanism becomes similar to what we discussed earlier, that is, release of nitric oxide, increased cyclic GMP levels, smooth muscle relaxation, and ultimately erection. Erection is also balanced by sympathetic system, which does the opposite. Sympathetic discharge causes smooth muscle contraction, leading to detumescence. That's why anxiety or stress can immediately inhibit erection. Detumescence is the process by which an erect penis returns to the flaccid state. So far, we can see that erection is not just a penile event. It is a coordinated neurovascular process involving the brain, spinal cord, blood vessels, endothelium, and smooth muscle. Therefore, any disturbance in these systems can result in erectile dysfunction. So the most common mechanism in the pathophysiology of ED is endothelial dysfunction. Conditions like diabetes, hypertension, dyslipidemia, and smoking damage the endothelium. In hypertension, a constant high pressure physically stresses and damages the endothelial lining of arteries, particularly small arteries and arterioles. In dyslipidemia, excess LDL cholesterol get deposited in the endothelium and trigger inflammation. Smoking introduces toxins and free radicals that directly injure endothelial cells. In diabetes, high glucose directly injure endothelial cells, leading to reduced nitric oxide availability. Without nitric oxide, cGMP is not generated adequately, so smooth muscle cannot relax. This directly impairs arterial inflow. At the same time, these conditions, along with aging, can also produce structural changes in the cavernosal tissue, such as fibrosis. Because of this, the tissue cannot expand properly, and more importantly, it cannot compress the subtunical venules. So even if blood flows into the penis, it is not adequately trapped and starts leaking out. This condition is called venous leak, and as a result, the erection either cannot be achieved fully or cannot be maintained. Another important mechanism is neurogenic impairment. As we see, sexual stimulation sends signals through the nerves to the penis, which then triggers nitric oxide release. But in conditions like diabetic neuropathy or spinal cord injury, these nerve pathways are damaged. As a result, the signal never properly reaches the penis, so nitric oxide is not released and erection cannot occur. Now, very importantly, the psychological factors like anxiety, depression, or performance stress can also lead to erectile dysfunction. Normally, erection requires a state of relaxation and parasympathetic dominance. However, in situations like anxiety, stress, or performance pressure, there is increase in sympathetic activity. The body essentially shifts into a fight or flight mode. This sympathetic overactivity causes contraction of the smooth muscle in the cavernosal tissue, which directly oppose the relaxation needed for erection. So even if blood vessels and nerves are structurally normal, the penis cannot achieve or maintain an erection. Now, an important clinical clue here is that these patients often still have normal nocturnal or early morning erections. Why? Because during sleep, sympathetic tone naturally decreases and parasympathetic activity predominates. So the normal erection mechanism works in that setting. But during intercourse, when anxiety or performance pressure kicks in, sympathetic tone increases again and erection becomes difficult. Now the hormonal causes, especially low testosterone, affect erection in a more indirect way. Testosterone is important for maintaining sexual desire. So when its level is low, the person simply has less interest in sexual activity. In addition, testosterone also helps in the proper functioning of nitric oxide synthase, the enzyme needed to produce nitric oxide. So when testosterone is low, nitric oxide production is also reduced. As a result, erection becomes difficult. Drug-induced ED is also very common. Now, an important point to understand is that it is usually not just the drug alone. The underlying disease for which the drug is being given, like hypertension or depression, also contributes. In fact, in older patients, these effects are often additive. The important ones are shown in this table. Among the antihypertensive agents, the thiazide diuretics and beta blocker have been implicated most frequently. These drugs either reduce blood flow to the penis by lowering pelvic blood pressure or directly affect smooth muscle function, leading to inadequate filling of the sinusoids. Drugs like CCBS may also interfere at the corporal smooth muscle level, although they are less commonly associated with ED. On the other hand, alpha blockers and ACE inhibitors are relatively less likely to cause ED. Some drugs act through hormonal mechanism. Medications like estrogen, GnRH agonists, spironolactone, and H2 blockers can either suppress gonadotropin production or block androgen action. This leads to reduced testosterone levels, which decreases libido and also indirectly impairs erection. Antidepressant and antipsychotic agents, particularly neuroleptics, tricyclics, and SSRIs, are associated with erectile, ejaculatory, orgasmic, and sexual desire difficulties. Among SSRIs, paroxetine and escitalopram have been associated with highest risk of sexual dysfunction, while drugs like bupropion, mirtazapine, and nefazodone are relatively safer. So if erectile dysfunction starts soon after initiating a drug, you should suspect that medication. In such cases, switching to an alternative may help. However, in many cases, it is more practical to treat ED directly rather than repeatedly changing medications, because proving a definite causal relationship can be difficult. Now, apart from drugs, factors like obesity and alcohol abuse also play a major role, and importantly, they often overlap and amplify each other. Obesity is strongly linked to insulin resistance and endothelial dysfunction. In addition, obesity is also associated with lower testosterone levels, which further reduces libido and erectile function. Chronic alcohol intake adds another layer. It can directly depress the CNS, impair sexual arousal, and over time cause liver dysfunction and hormonal imbalance, leading to reduced testosterone levels. It can also contribute to peripheral neuropathy, affecting the neural pathways required for erection. And this is the pathophysiology of erectile dysfunction. In the next lecture, we will discuss how to approach a patient with erectile dysfunction and explore the appropriate treatment options.